Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's lecture is on osteogenic bone tumors. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, don't forget to press the bell icon below to get my videos regularly. Orthopedic oncology involves the diagnosis, management, and surveillance of primary mesenchymal malignancies or sarcomas, benign bone and soft tissue masses, and secondary neoplasms of bone and soft tissues. The term bone tumor is a broad term used for benign and malignant neoplasms as well as tumor-like conditions of the bone like osteochondroma. Metastatic deposits in the bone are commoner than primary bone tumors. The unique structural qualities of bone and its complex microenvironment must be considered during the management of bone tumors. An understanding of what the tumor is doing to the bone, what the bone is doing to the tumor, where the lesion is, and how the treatment impacts the future quality of life of the patient are key considerations. The most common malignant bone tumors are secondary metastatic carcinomas. They mostly involve the long bones of the extremities. The most common bony metastases originate in the breast, prostate, lung, kidney, and thyroid. Hematopoietic tumors like multiple myeloma may also arise in the bone. Multiple myeloma is a malignant neoplasm of plasma cells in the bone marrow leading to multiple skeletal lesions. Multiple myeloma is the most common primary bone cancer. When solitary, this plasma cell tumor is called a plasmacytoma. Primary malignant bone tumors or sarcomas are rare and account for less than 1% of total cases of cancer. They occur mainly in second decade of life, that is, in children and young adults with a male preponderance. The most common primary bone cancers are multiple myeloma, osteosarcoma, chondrosarcoma, and Ewing sarcoma. Osteochondroma is the most common benign bone tumor, accounting for between 35 and 40% of all benign bone tumors. Most primary malignant bone tumors occur in children and young adults. The diagnosis of bone tumor is established by a combination of clinical, radiological, and pathological examination supplemented by biochemical and hematological tests wherever necessary. Blood tests include serum levels of calcium, phosphorus, alkaline phosphatase, and acid phosphatase. Specific investigations like plasma and urinary proteins and the bone marrow examination in case of myeloma, urinary catecholamines in metastatic neuroblastoma, and hematologic profile in lymphoma and leukemic involvement of the bone are also very helpful. The bone tumors are classified according to the tissue of origin or the matrix they produce. The rest are grouped by clinico-pathologic features. Most primary bone tumors are benign. Metastatic tumors are more common than primary bone tumors. Although primary bone cancers do not have a clearly defined cause, previous cancer treatment with radiation or chemotherapy, a stem cell transplantation, and certain inherited conditions increase the likelihood of developing these tumors. Osteosarcoma occurs more frequently in people who have had high-dose external radiation therapy or treatment with certain anti-cancer drugs, particularly alkylating agents. Those treated during childhood are at particular risk. In addition, osteosarcoma develops in a small percentage of children undergoing myeloablative hematopoietic stem cell transplantation. Children who have had hereditary retinoblastoma are at a higher risk of developing osteosarcoma, particularly if they are treated with radiation. Members of families with Li-Fraumeni syndrome are at increased risk of osteosarcoma and chondrosarcoma as well as other types of cancers. Additionally, people who have hereditary defects of bones have an increased lifetime risk of developing chondrosarcoma. The development of osteosarcoma has been linked to various genetic mutations and abnormal signaling pathways. RB mutations are present in up to 70% of sporadic osteosarcomas. About 20% of sporadic osteosarcomas show mutation in TP53 tumor suppressor gene. RB gene mutations are seen in hereditary retinoblastomas and TP53 gene mutations are seen in Li-Fraumeni syndrome. Some other causes are inactivation of CDKN2A or overexpression of MDM2 and CDK4 genes. Osteoid osteoma is the commonest true benign tumor of the bone. It arises from osteoblasts. The tumor is seen commonly between the ages of 5 and 25 years with a 2.5:1 male to female ratio. The bones of the lower extremity are more commonly affected, tibia being the commonest. The tumor is generally located in the diaphysis of the long bones within the cortex. Posterior elements of the vertebrae are also a common site. The diagnosis is usually confirmed on X-ray. There is a zone of sclerosis surrounding a radiolucent NIDUS, usually less than 2 cm in size. The actual neoplasm or NIDUS is a small radiolucent core which is surrounded by reactive bone. The presenting complaint is severe pain, worst at night, that is caused by prostaglandin E2 produced by the proliferating osteoblasts and is typically relieved by NSAIDs, non-steroid anti-inflammatory drugs. Osteoid osteomas can cause effusions in a nearby joint. The treatment of choice is CT-guided thermocoagulation or radiofrequency ablation, but complete surgical excision of the NIDUS along with the sclerotic bone can be done alternatively. Malignant transformation is rare. Osteoblastoma is a benign, locally aggressive, expansile, and osteogenic primary bone tumor. It also arises from osteoblasts and has histopathologic similarities to osteoid osteoma. It accounts for about 1% of all primary bone tumors and 1 to 5% of all benign bone tumors. It usually occurs in the jaw and the spine. If in long bones, it occurs in the diaphysis or metaphysis but never in the epiphysis. The most common presenting complaint is a dull and aching pain which typically does not respond dramatically to NSAIDs and is not generally most severe at night in contrast to that in osteoid osteoma. It occurs in the second decade of life. This tumor occurs in the second decade of life. Diagnosis is made radiographically by a characteristic lesion that is more than 2 cm in diameter with a sclerotic rim and radiolucent NIDUS. Osteoblastoma is considerably larger than osteoid osteoma with an average diameter of approximately 4 cm. Osteoblastoma must be managed surgically because of its potential for aggressive behavior and bone destruction. Treatment is by curettage and bone grafting. Malignant transformation is rare. Osteosarcoma is a highly malignant bone-forming tumor. These arise from pleomorphic osteoblasts that produce too much osteoid tissue. It is the most common primary malignant bone tumor and accounts for approximately 20% of bone cancers. These tumors usually arise in the metaphysis of the long bones. Almost 50% are near the knee in the distal femur or proximal tibia. The age distribution of osteosarcoma is bimodal. 75% of cases occurring before 20 years of age. The peak incidence is during the adolescent growth spurt. The tumor arises most frequently in the growth plate of rapidly growing bones. A second peak occurs in older adults after 45 years. Here it is frequently associated with some predisposing conditions such as Paget's disease, bone infarcts, multiple enchondromatosis, fibrous dysplasia, and prior radiation. The secondary tumor has a more aggressive behavior than the primary osteosarcoma. In this setting, it is called secondary osteosarcoma. Males are affected 1.5 to 2 times more often than females. It produces mixed lucent and sclerotic lesions with breach of the cortex and soft tissue extension. The classification of osteosarcomas is complex, but 75% of osteosarcomas fall into the classic category, which includes sclerotic, chondroblastic, fibroblastic, and telangiectatic types. RB mutations involving chromosome 13 are present in up to 70% of sporadic osteosarcomas. Its most common site is distal femur, followed by proximal tibia, proximal humerus, and distal tibia. Osteosarcomas infrequently penetrate the epiphyseal plate and enter the joint. Patients typically present with pain and swelling of the affected area. Usually osteosarcomas are intraosseous, but they can also arise from the surface of bones. Then it is called parosteal osteosarcoma. Most osteosarcomas are high grade. The parosteal osteosarcoma is a low grade osteosarcoma. Tumor cells can also produce cartilage. Such tumors are classified as chondroblastic osteosarcoma. Intravascular invasion and hypervascularity are common features. In osteosarcoma, a plain radiograph reveals a destructive lesion with a moth-eaten appearance or as a speculated periosteal reaction known as sunburst appearance. Also, there may be a triangular shadow between the cortex and raised periosteal ends known as Codman'sTriangle, indicating its aggressive behavior. A CT scan of the tumor is best for defining bone destruction, whereas MRI is better for defining intramedullary and soft tissue extension. A chest radiograph and CT scan are used to detect lung metastasis. Metastasis to the bony skeleton should be imaged by a bone scan or by fluorodeoxyglucose positron emission tomography or FDG PET. Almost all osteosarcomas are PET positive. Pathologic diagnosis is established either with a core needle biopsy or with an open biopsy. All osteosarcoma patients are assumed to have occult metastasis at the time of diagnosis. As a result, the osteosarcoma is treated with neoadjuvant or preoperative chemotherapy followed by limb-sparing surgery and adjuvant or postoperative chemotherapy. The effective drugs are doxorubicin, ifosfamide, cisplatin, and high-dose methotrexate with leucovorin rescue. Long-term survival rates in osteosarcoma range from 60 to 80%. Osteosarcoma is a radio-resistant tumor and radiation therapy plays no role in its management.